Good afternoon, good morning, welcome everyone, depending on where you are and the time zone that you're in. We're really pleased to be with you today in this conversation about telehealth chaplaincy and approach for chaplains to meet clinical needs during COVID-19. My name is Wendy Cadge. I'm a professor of sociology at Brandeis University outside of Boston and one of the founders of the Chaplaincy Innovation Lab. We're working quickly and doing the best we can through some amazing staff of the lab to respond this week and to try to be there for you and with you and bring you what you need in this time. So we're really thrilled to have a set of people here to talk with us a bit, and we're going to get to Q&A pretty quickly. All of these folks have done telechaplaincy or have studied telechaplaincy, and so let me introduce them, and then I'm going to turn the floor to them. Petra Sprik will begin. She's a staff chaplain at Levine Cancer Institute at Atrium Health, with Deborah Ingram, who is the Chaplain Connect Program Coordinator at Advocate Aurora. They're going to be talking about two different projects that they did related to telechaplaincy. Daniel Grossoehme, who was a pediatric hospital chaplain for 25 years and is now a full-time palliative care researcher, will talk about a project that he did about telechaplaincy with pediatric patients and their families. And we're thrilled to have Amy Simpson here, who was one of the staff chaplains who did telechaplaincy as a part of this project at Cincinnati Children's Hospital. So we'll hear from Amy. And then Kurt Nelson, who is a chaplain at Bucknell University, will wrap up. We're focusing a lot today on healthcare for all the obvious reasons, but we know that our colleagues in lots of settings who are chaplains are switching to telechaplaincy, and we wanted Kurt to tell us a bit about what's happening at Bucknell in a way that might be helpful for others of you. Trace Hawthorne will lead the conversation. He's the Executive Director and CEO of ACPE, the Standard for Spiritual Care Education. And all of the materials that we're sharing today, as well as the articles we're discussing, are or will be sent to you either during this webinar or this afternoon when the video will be available. So thanks again for being with us. You can type your questions in the question box or in the chat box, and we'll do the best we can to get to them. And a big thanks to all of our panelists for putting this together so quickly. Petra, I'll hand it to you.
Debbie and I will start by presenting a little bit on practical advice that we have accumulated in our own practices. I've been doing telechaplaincy for about 6 years, and Debbie for just over a year herself. And so we'll go into some systematic approaches and then just basically how do we do this. And then we'll turn it over to the other panelists. So telechaplaincy is a new thing for a lot of people. And so I just wanted to start off by saying, what is it? And basically it is communicating by telephone, smartphone applications, live video conferencing, internet interventions to deliver virtual care, healthcare. In our case, it would be chaplaincy. And this can be done both in real time, as we're doing in this webinar, we are chatting, or it can be something that's done where we record something now and then it is made available to patients or families later, such as a video, and all of that can count. And so a lot of people, when we start talking about this, have some fear. So let us help with that and say, this has been happening for a while. We're joining a practice that has been being developed since physicians were making early house calls. As some of our panelists will tell you in presenting their own research, we know that telechaplaincy is feasible and it's acceptable with a variety of different patients. Some patients prefer it to in-person care, and we know that it can help reduce spiritual struggle and it can increase spiritual well-being, and there's certain parts of it like anonymity and being monitored that patients really appreciate. And so why do we use it during COVID-19? One, it's recommended by public health organizations. And as we know, if we're not going into rooms, we can prevent the virus from spreading to patients, families, staff, yourself, which is pretty important. We can also operate within healthcare systems directives conserve personal protective equipment that healthcare providers will need during this crisis, reduce fear for patients and family, and then we can really expand who we can reach by using these technologies. This time I'll turn it over to Debbie to talk a little bit on her advice on implementing a system.
Okay, thank you, Petra. So as we're looking at developing a system, we want to encourage you to think systematically and gather a group together to do that. What are the situations you're going to find yourself in? So think about your current model of care, and is that something that you can carry over into a telechaplaincy environment, or do you need to maybe think about redefining your model of care? What are you going to respond to? Medical codes, spiritual care visits? Do you do advanced care planning at your site? So really get that defined for yourselves. Also, I would encourage you to think about what is sustainable for you and for your teams. You know, there's been a lot of conversation recently about our planning through the end of March, but as we're really following kind of the trajectory of COVID-19, I think we're becoming aware that this is really going to take us into the summer. And so what is sustainable for your hospitals, your healthcare systems, and for your teams as well? And then what is the most ethical way to respond? So do we need to be in the room? Is that the place for us to be? And how do we respect the agency of our patients and families as they may be expressing their own concerns about transmission? And then adapting to the restrictions within our healthcare system. So really just encouraging you all to stay up to date on the policies within your own healthcare system. And so moving on, we want to also be proactive and do our best to address next steps before they happen. So how might we engage chaplains remotely, and what if we find that our chaplains are being furloughed? So recently, just this week, we did a technology inventory with our chaplains and identified who has access to laptops, who has the ability on those laptops to access our network from home. So really thinking strategically about what resources are available to our chaplains today and how we might be able to use those resources to keep people offering patient care even if we find ourselves working from home. So do not expect healthcare systems and telehealth platforms to address chaplaincy as the priority. This comes from a conversation that Petra and I were having earlier this week. I have been working on some telechaplaincy initiatives for the last year. And 6 months ago, I was having conversations with groups and they were really telling me that they had the capacity to get a telechaplaincy program up and running for us. I went back to those groups last week, and because of COVID-19, they are now really at capacity and can't help us get our program up and running. So we're having to think creatively about other ways to deliver care to patients via telechaplaincy. And then using existing systems. So what do we have access to? Phones, iPads, in-room access. Can we deliver care synchronously? Can we deliver care asynchronously? So what do you have access to? Even pager technology, I have been investigating within our system. We might think of that as old technology and therefore not viable technology, but I've been looking at models that will allow us to cover multiple hospitals with one pager. So how can we leverage and access what we currently have in place? And so I would encourage you to be in communication with the folks in your IT departments, in your communications departments, really engage with your networks within the hospital and see what is, or wherever you're working, and see what is available to you. And so I really just touched on that before. So use your professional networks. What are colleagues in other systems doing, as well as who do you know within your own system who might be able to direct you to technologies and platforms that you weren't previously aware of and that you might be able to use to deliver care over the phone or over video. And then ask your administration about HIPAA compliance. So Skype and Zoom may not be considered HIPAA compliant. I've recently learned that different versions of Epic have the ability to offer video chat and video conferencing that would be HIPAA compliant. So again, talk to your in-house folks and see what is available to you from a HIPAA compliance perspective. And then I think we have one more. Thank you. And then just getting back to that question of respecting family and patient agency. So asking ourselves the question, why am I going into the room? Am I going into the room because it's what's best for the patient, or am I going into the room because it's what I'm used to and feels comfortable for me? And allow, be thoughtful about that question and allow it to guide your steps as you move over. So having said that, I will turn the presentation back over to Petra.
So really quickly, we're going to cover some advice on delivering telechaplaincy, and this comes from 3 different studies that I did. One on it's in process nationwide study surveying chaplains and what they're doing to deliver telechaplaincy, and then 2 studies that we did on the feasibility and acceptability of telechaplaincy at our Cancer Institute and how patient-reported outcomes can be used. So the big piece of advice is almost everybody said in this nationwide study that they were nervous of doing it the first time. And when asked what advice they would give, they said, just do it. So go ahead, give it a try. Don't be afraid of it. The more you do it, the more comfortable you'll be with it. The other is, another piece of advice is to check the patient's chart before you call if you're able. So you don't have the context clues that you might have when you enter a room. So can you look at the patient's diagnosis, who their emergency contacts are, if there's any social history. Any of that can help you have a more successful phone conversation or telehealth visit. Develop a loose script. So we know that chaplaincy is an art and you can't stick to an exact script, but especially in the beginning, having a loose script can help you deliver unified service. We found that to be effective when we were developing our own programs, and some of those scripts will be made available to you. Develop a casual introduction. So what we know from one of the studies is that about 25% of people are nervous when they are, or have some form of fear when they are receiving a call from a chaplain. And so introducing yourself from the spiritual care department rather than saying this is a chaplain can be helpful. Or having just a casual conversation as you enter the conversation, saying up front you don't have any medical information. All of that can help you have a better interaction. And to ensure that you're talking to the right person, that it is a good time to talk. So we can't see what people are doing when we call them unless it's a video conference. And so respecting their autonomy, they might be grocery shopping and looking for toilet paper, and that's not the best time to talk to them. So go ahead and ask up front whether it's a good time to talk. And just because of HIPAA compliance, make sure you verify that it is the patient. If you are calling them at home where you might be leaving a voicemail, think through the voicemail before you call, Because, for instance, at Levine Cancer Institute, it's not HIPAA compliant for me to say that I'm calling from the Cancer Institute, because that can give away some diagnoses. And so come up with that wording beforehand. It can also be intimidating to leave a voicemail the first time, so that can help with this process. Be creative as you deepen the conversation. So these are a few things that we have found helpful. Sometimes when chaplains are nervous, the conversation doesn't go very deep because they're trying to get off the phone. Think about talking to your mom or family on the phone. There's certain things that you can say to start to deepen that pastoral conversation. And then have ways of getting off the phone. So that's the opposite of, there's patients who don't really talk easily on the phone, and then there's those that could easily talk for 2 hours, and we're trying to reach a lot of patients. So establishing boundaries is something that's important. Say, I will need to go in 5 minutes. Is there anything else you want to talk about? You can schedule a follow-up visit. All of those are good ways to get off the phone. And then we'll pass it on to the next presenter and take questions later.
Hello, everyone. I'm Daniel Grossoehme, currently at Akron Children's Hospital. Wendy asked if I would talk a little bit about a study that Amy and Judy McBride and I did at Cincinnati Children's. I was interested in looking at ways to improve parents' treatments, or ways to improve parents being able to complete their child's treatments for cystic fibrosis. One of the things we know is that parents with symptoms of mild and moderate depression really struggle to get their child's daily therapies done. And we also knew that one of the things that can exacerbate depressive symptoms is spiritual struggle and negative spiritual coping. And so I was wondering that if we had a chaplain who had a fairly structured, semi-structured interview kind of intervention to deal specifically with spiritual struggle, if that would turn down the volume, so to speak, on the depressive symptoms, and that would enable them to do a little bit better job adhering to their child's therapies. And so in some sense, because this was a study, the setting's a little artificial, but we went into the outpatient CF clinic and screened parents for symptoms of spiritual struggle. And if they screened positive, they became eligible to participate in the study. And about 3/4 of those who were eligible did agree to participate and enrolled in the study. And they were randomized either to a control condition, in which case they got a phone call from my research coordinator who talked about the importance of hand washing and other things that were guaranteed not to affect your spiritual struggle, or you were randomized to a series of 3 roughly 30-minute phone calls with one of the 2 chaplains. Each of the 3 phone calls was spaced about 2 weeks apart. One dealt with spiritual struggles within an individual, the next one spiritual struggles between people, and finally one's own spiritual struggles with the divine, thinking that that would be an increasing depth of conversation. We didn't think they'd want to perhaps talk about spiritual struggles with the divine right in the first few minutes. All of these were designed to be carried out by a chaplain in their using hospital phone, which sort of helped with some of the HIPAA compliance issues. We did not envision them, and I don't believe either of them actually used their personal cell phones at any time with that. And generally, it went very well. There was, as to be expected, some missed call appointments. All of these phone calls with the chaplains were scheduled in advance. And it typically took 2 phone calls, 2 attempts to actually accomplish 1 phone call. But it rarely took 3 or 4, only in a few cases. I'll let Amy talk about the experience of doing it. I will say in terms of the results, the people who received the intervention, by the time 2 or 3 months had passed, their spiritual struggle was lower, their depressive symptoms were lower, and they were actually using more positive spiritual coping. But in the meantime, shortly after they had their 3rd phone call, the level of spiritual struggle actually increased. And so it sort of looks like by going in and intentionally dealing with some of the issues, they may temporarily have scored a little worse on the scale, but ultimately ended up scoring much lower and reporting feeling much better about it. Probably the same thing happens when we come and go in a room, but we had never measured that and don't really have the numbers to back it up. But that's just something to be cautionary about. And let Amy pick up here and talk about what it was like to be the chaplain on the phone.
Thanks, Daniel. And I was excited to try these interventions alongside Chaplain Judy McBride. I was also nervous, but let me just start by saying it works. And what I mean is there were some difficulties and some challenges with it, but I honestly was so surprised at how deep people got on the phone. And it helped, just like Petra was saying, to have a script. There were some specific questions we wanted to ask. We could obviously use our own style of conversation to do that. And Daniel put together some prompting questions as well. If there was kind of like well, what do you mean by that? Or just a yes or no, which we tried. Obviously, we didn't have yes or no questions, but when they would just kind of answer briefly. And that was really helpful too, because I think it helped me remember that we can go a little bit deeper with the conversation, and it helped them also to understand a little bit more of where we were going. Judy McBride had an instance where she was talking to a mom while they were at the pool with her kids. So there are things, obviously, when you're calling people on their phone, they're doing other things. And so being open and saying, having a script, what you're going to say when they answer the phone, and then ask them, is this an okay time to talk? I think that gives them an option to say, no, let's try something else or a different time. The nonverbals, not being able to have the verbal cues that you have in conversation, can get a little tricky sometimes. So you have to be willing to have the silence, because you can't, you can see when somebody's thinking. You can watch them before they answer and they're quiet, and you can tell that they're thinking, they're going to give you an answer. You can't do that on the phone. And so being willing to have a little bit of that silence. And then I just was really honest and would say, so I noticed you're silent. I can't see you, so I'm not sure if you want to answer this question. If you don't, if you're thinking about it, I want to be mindful of what's you're doing. And I think the more honest we could be over the fact that there are some limitations when you're talking to somebody on the telephone, it just seemed to go a little bit better, because then they would say, yeah, hold on a second, let me think about that. And that helped with the conversation too. So I enjoyed it tremendously. I think it was so successful. I had one dad who, after the third, because we recorded these and we told them we were recording them for research purposes. And after we were done, he said, can you please email me those transcripts? Because it was so helpful to be reminded how I could use my spiritual and religious resources to help me during this time. And that was just, I thought, oh my gosh, yes, of course we will. And that just was so helpful to know that he wanted to look back at those later and have those conversations later. Since then, this week with the COVID-19, and I was part of a situation where there was a potential exposure, and I watched what happened this last weekend with some staff where they had to be in quarantine for 14 days, some nurses. And all of a sudden it hit me like, oh my gosh, I don't want to be that person that says, I might have this, and now I have to go back and tell everybody who I was with, the patients I was with, the staff, and to have them be quarantined. And so I worked closely with the rest of our leadership team, and we came up with a process where this week we went to telechaplaincy. Now, we weren't prepared. We were a little bit prepared to do that, and we're lucky because we have some good resources to be able to do this. But we did it right away. Our IT team was amazing in getting us VPN access to those who didn't have it, getting our workstations up and running. We figured out we have the Bolt phones in our system, and so we figured out how to do that on our cell phones. And then they also set up, I'm going to pronounce this wrong probably, I think it's Avaya workspace. And that's how we are calling from our cell phones, and it shows when we're calling another home phone or a cell phone, it shows that it's coming from the hospital as opposed to
our own personal number, and they got us hooked up quickly on that. And so that has really helped us now call in and do our spiritual screenings and our assessments. And we have changed our script to include the fact that we're reaching out to them by phone for the safety of, I'm in a pediatric setting, their child, them, and the staff. And instead of in person, to decrease the amount of people in the room and the potential exposure, but that we are still available to provide care and wanted to check in on them. And that has been really successful with my colleagues. And I want to say one of the things that we have thought about is how can we be creative using this? And especially with staff support with families, you know, we're calling them, but the staff are really, because we're down to one person in-house now, and that was difficult for them. And as a matter of fact, some of the feedback that we've gotten, it's been a little bit more difficult for our staff when we're not just immediately responding to medical teams or traumas, but we're triaging those. But the families, when we call them, they say, oh, thank you. We're so appreciative you're doing it this way. So we tried to be creative in ways that we can be reaching out to our staff. And we have some younger staff than me that got on and did a YouTube video, just in 5 minutes. So I obviously am older than them and am not as good at that kind of stuff. But they created a YouTube video and they sent it out to their staff and just said, hey, we're here. We understand you're going. This is a difficult time. You know, these are some things you can do. And then one other thing that's happening actually later today is we had one of our chaplains has a patient who was actually with us 372 days. And it was a cancer patient, and she unfortunately died. And so the staff really got to know her and her family, and we're planning to go to the funeral. Well, they can't go to the funeral anymore. So what she has done is she had the staff give her memories, things about the patient, little stories, and she compiled this list and sent it to the family. And so the family members are going to read those at the funeral. At the same time that the funeral is going on today, this staff chaplain is conducting a time for the staff to come together on Skype, and she's going to have a little remembrance service. She's grabbed our music therapist who's going to provide music. She has a candle she's going to light, and she's going to read those stories. And so this family knows that this is happening at the same time. The staff feel cared for, and she was just surprised at how many staff want to be a part of this. So I think the more creative we can be, obviously reaching out to our patients and families, but also to our staff in ways that we can provide care. That's just been some of the things that we've done here in Cincinnati. Thank you.
I think it's me next. Greetings from the world of higher education. I hope everyone's staying healthy and grounded as possible in this moment in time. Wendy reached out to me 2 days ago to see if I'd say a little bit about what we're up to at Bucknell, which feels a little ironic. I've been doing telechaplaincy for 6 days now, so I feel like an expert for sure. Been resistant my whole career to try to get people connected digitally, really working to get face-to-face meetings, but here we are. I was actually traveling last week with a group of 8 students for our immersive interfaith service experience. We were in Baltimore working on food justice issues when Bucknell sent the message out saying that we're shut down for the rest of the semester, going totally remote, and that life is different. I think colleges and universities tended to be the early adopters in many cases on these measures, and I got to see our students process in real time kind of what they were going through. And what it really is grief, right? As we're working through this moment in time and figuring out what life is going to look like, it looks like grief. And just a little bit of presence with them during that time, brought back all of those angry feelings toward administration, all those confused feelings, and really brought it back to that sense of grief and ability to process. And I think there's really good work to be done. So we got back and we just tried our best to move everything digitally where we could. And I noticed, I think, 3 things in particular. Number one, that a lot of our folks, students, staff, admin, faculty, are anxious in this moment and really busy. Number 2, a lot of our folks are anxious in this moment and really bored. They don't know what they're supposed to be doing. And then number 3 is that our leadership is getting an incredible amount of abuse via digital means based on decisions they're making and timeframes and things like that. And those all feel like places where we can be present with text messages and phone calls and digital meetups for the folks who are running around trying to figure out what's going on and the folks who have no idea what they're supposed to be doing hour by hour. Full disclosure, I'm one of those people for sure, and present to the folks who are getting a lot of angry messages from people who are really grieving, but turn toward anger as a pretty natural response. So we moved all of our services, all of our tech studies online. We're going to try all of our regular groups as much as possible via Zoom meetup and Facebook Live and those types of things. And we're really trying to make space with twice a week sessions for members of our community to share the practices that are sustaining them in this moment in time. And those have just started, and I messed up the Facebook feed, but really, really positive glimmers of hope for those moments. So people are showing up. That would be the thing that I would say. So try, Zoom is a great program. Facebook has its problems, but folks want to show up. Folks want to be together. Folks are certainly lonely and disconnected and anxious. Some of them running around like crazy. Some of them more bored than they've ever been in their life. And some of them taking heaps of abuse in this moment of time. And so I feel confident across our various types of institutions that we can be meaningfully present in those ways. Thanks.
Thank you, Kurt. That was great. We've had several questions and I've tried to group them as we've gone along. I'll do my best to get to as many of them as we can. But let me just start with a quick one. Several people have asked about scripts and PowerPoint. Yes, we will try to make those available with the recording. So thank you to the panelists for your content that you've got there. I know that Amy talked about Avaya or Avia as one possibility. If you look in the chat box or in the question box, you'll see that we've posted the link to that. Thank you to Aaron for finding that for us. What other platforms are you all using for telechaplaincy? And I think that's specifically to Petra and Deborah.
So honestly, I'm working remotely, and we were instructed to dial *67 from our cell phones to make it anonymous, and are calling people that way. One of the negatives of that is people tend to distrust anonymous numbers. So I will warn you that we've had less success with that than when it comes from our hospital line. I did make them from my work phone prior to that. And then to just join the voice and continuing to think that word is not going to come out, not in real time. So we are also using various mediums like YouTube, SoundCloud. You'll have to check with your organizations. And I've been doing guided meditations, prayers, and that has been a resource that I can offer to people on the phone and that they've really been connecting with pretty frequently. So those are some of the ones we're using, and I'll pass it off to Deborah.
Okay, thank you. So as I mentioned, we have had to be somewhat creative in this time, and so we are using an application called Perfect Serve that typically is used for paging on-call physicians. But we've been working with the Perfect Serve team, and they are setting up basically a queue for us within Perfect Serve so that multiple chaplains can be present in this queue at the same time. And then staff, either via the Perfect Serve application on their desktops or also an 800 number that we're going to be providing, can reach out and place their requests into the Perfect Serve queue, and then it will be assigned to the chaplains within that queue based on chaplain availability. So it's not a typical use for that application, but we've been able, again, to get creative with what's available to us right now and use that, provide patient care.
Can I
Great.
just, Trace, may I just jump in here? So one of the things, I mean, we've even used, we have a pastoral care email box that we send emails out of. And so we are now creating that as a way that staff can, because we've, suspended all services, worship services and religious services there at the hospital. So we are opening that up so that staff can be reaching out their prayer requests to us that way, as well as families. And so we're starting that process soon, and then we'll have a chaplain each day responding to all of those as well. So it could be as easy as setting up a group email for your staff to be able to send stuff in.
That's great, thank you. And another kind of legal / technical question. One person understood from their administration that CMS has waived some of the HIPAA requirements during the COVID-19 around communications. Any confirmation of that from any of you all?
This is Jennifer Cobb. I can confirm that. The Office of Civil Rights removed that earlier this week. Talk with your local organization, but we're in preparation to contact patients via FaceTime, Google Duo, Skype, etc. And it's only for this period of national emergency.
Great. And Jennifer, I'm glad you're here. Can you say a few more words about what you all have been doing?
Sure. So at Mercy, one of the things that we've been involved in telechaplaincy for a very long time, normally making phone calls. However, given the level of staff stress right now, as well as the number of COVID-19 patients who will be in quarantine at home, on top of all of our other patients, we are planning to make phone calls to patients at home, as well as contact them by those other means that were previously mentioned. We're also anticipating contacting inpatients that way so that we limit the number of chaplains who are going in and out of those kinds of isolation rooms and conserving the PPE for the staff who need it. We're also exploring ways to help connect patients and their families via FaceTime or these other apps, because as visitors become increasingly restricted, the need for community and connection to family is going to be increasingly important. And so we're anticipating finding ways whether families and patients connect on their own devices, whether we end up providing some devices, but more and more digital connection, both for patients who are admitted, those who are at home, and then mass text messaging for staff. I loved the idea about the guided meditations, Petra, and other ways to connect or ways to push out resources as well.
Thank you, that's great. The other resource that has been mentioned to us, some of you already have bone marrow transplant units or isolation units where they figured out a lot of this a long time ago, both for people who are nonverbal as well as people who are isolated and can't connect with other folks. And so I would encourage people, when they have one of those units within their own institution, to take a look at what's happening there too. That leads me to another question around working with elders, especially those who may have hearing issues related to telechaplaincy. Can any of you speak to that?
So that is one of the reasons why I always check the chart before calling. One, to be aware of language issues or things like that. Two, to be aware of if they might be on a trach or if they have hearing issues. Sometimes people are able to hear on the phone and sometimes they're not. Sometimes the phone actually is clearer for people with hearing issues, and I've heard that again and again for patients. Roll with the punches, be aware of it if you can before you call, but sometimes it means talking to a family member. So checking in the patient chart and seeing if you have that permission to talk to a family member or not is pretty important in this process. And it won't be perfect. Sometimes it's going to be clunky. Hearing issues, speaking issues, asking people to repeat themselves, reminding ourselves that we're all human in the process, but definitely can present an issue, especially if someone's deaf, but see who you can communicate through in those cases.
And somebody noted also somebody with breathing problems who might have difficulty just getting words out within telephony, how hard it is to be able to communicate in that way.
And sometimes I've said, it sounds like you're out of breath. Can I call you back at a later time? Or is there a better time to talk? Or just getting it done 5 minutes at a time and following up 5 minutes every day.
That's great. Thank you. Daniel, somebody asked specifically what the screening tool is that you all used in your research.
Sorry, it took a minute to figure out how to unmute myself. We used the brief ARCOPE by Ken Pargament and specifically pulled out the 7 negative religious spiritual coping items and screened that. I believe the options are like, I have never used this coping style. I've used it occasionally. I use it a lot. I use it most of the time. Any response other than I don't use it was considered a positive screen, at least enough to warrant a phone call to check out.
Nice, thank you.
Let me leap in back in.
Yep.
This study is now 2 years ago, Amy. If I were to do it today, I would use the spiritual struggle scale that was put out by Julie Exline and colleagues from Case Western University. And I think the date on that is 2018 or 2017. Either of those scales are good, but if I did it today, I'd use Julie Exline.
If you all look in the questions, circling back to the earlier question about HIPAA constraints, there is a link now. Edward Bernstein has put into the question box that is the HHS announcement, so you can see the actual document related to that. Thank you for that, Edward. It's nice to, it takes a village. It feels like we've got all hands on deck right now. So even in this webinar, we really appreciate the help. Let me toss out another question that is interesting because it was asked in 2 different directions. One person asked if it was ethical to not go into a room when doctors and nurses and therapists are. Another person asked if it was ethical to go into a room when all the procedures were saying we shouldn't and that we were increasing the virus vector. What do you have to say, panel? And that's a wrap. Thanks very much. We had a nice day. Everybody is pretending like you can't find the mute button.
I think one of the things regarding ethics is we have to think of the motivation behind it. Are you going into the room out of your own, I need to get in there and I need to create a change? Is the clinical team telling you something? You know, if a patient's dying, that's one thing. If a patient just might be a little down one day, that's another. So considering those circumstances. And I think part is, why do you have to be in person? Each room has a telephone. In the case of a dying patient, of course, that's not going to work. In case of a patient who's sitting there and able to talk on the phone, why not give that a try first? Maybe use it as a screening method. So I haven't thought of all the ethics of this, but you know, people are unnerved, and yes, we are essential to the work, but we're essential in certain cases. And so how can you screen for those cases might be a good ethical question to ask just before knocking and entering. I think rounding is pretty unethical.
That's helpful.
I think it's really hard because it's been difficult for us because there is such a benefit in being in person. And so our team has met every morning for an hour-long Skype call to go over these changes, and I'll be honest, we have struggled. I think it's one of those where we are not trying to say that it's not important that it matters to have a chaplain there in person. That's not it. We are in a situation that is new. And sometimes the best care that we can give is by not being there in person. And I, again, go back to that. I don't want there to have to be 14, 20 nurses or medical team member nurses or doctors that have to go in quarantine because I needed to be there in person. And so it is tough, and it's not, I keep reminding our team and myself, this isn't permanent. This is for now. Not that telechaplaincy we can't use it all the time. I think this is excellent. It's giving us an opportunity to try something that we might not have tried, or every one of us would have tried. So, I just think it's for a brief time.
Yeah, it's certainly a time of great experimentation. Let me go to Kurt specifically. Somebody asked if you could talk about those twice weekly check-ins. What's the format for those?
Yeah, so we've asked members of our community just to share for 5 minutes about, we're calling it sustaining practices for perilous times. So I just introduce them. They talk for 5 minutes about practice that's meaningful to them. We open it up for 5 minutes of questions and let folks go on their way. You can see them on Facebook, I promise, next time, Tuesdays and Thursdays at 3. If you want to join us, you're welcome to Rook Chapel at Bucknell University. And it was our Zen advisor who shared the first one, and he just, gave a really lovely 5-minute take on breath meditation and told people to be gentle with themselves. And on Tuesday, we'll hear from our Muslim chaplain, and I imagine he's going to talk to us about prayer practice.
That's great, thank you. Take a look in the question box and you'll see some resources from some other folks too. The folks at the Brigham and Women's Hospital developing an spiritual care Instagram account for staff. And then there's also a series of questions about doing telechaplaincy with other constituencies. So I talked about elders. There's a question about working in behavioral health. There's another about working with people who have limited English or non-native speakers, or maybe don't even have English. How does it work in those contexts? Can you all speak to either of those?
From serving chaplains across the U.S., there's various ways that people have mentioned. So some healthcare systems, for example, a Spanish-speaking patient, have an interpreter that you can have as a third line coming in. And so that could be an option for that. So I would talk to your interpreter department. If that doesn't work and email is permitted, or you get an agreement from the patient in person that email, you can use translators that way as well, or various people have. Behavioral health, different organizations have different practices, and my guess is it looks different with COVID-19. So again and again, I heard from behavioral health practitioners that patients actually wanted it. For a lot of behavioral health patients, gave them a sense of peace, because they didn't have to, for example, with schizophrenic patients, they didn't wonder as much if the voices they were hearing when the person was on the phone were real, and they could engage in a different way. And I heard that from several chaplains. But I would, in that case, if that's your environment, be talking to other practitioners, be talking to the psychologists on your team, be asking whether that's appropriate. And it'll vary. So I think just remembering we're not alone, especially in COVID-19. I think various practitioners will talk across and say, yeah, I would recommend this, or I wouldn't recommend that, and functioning as part of that team.
A question too, a couple of different versions of this question about, so particularly when a patient dies from complications related to COVID-19, the family often is not allowed to be present at that point. They may not have been present for several days. Has anyone developed any kind of process for grieving? And know that, let me caveat this by saying we're working on a webinar specifically about this. So be curious to hear if you've got any seeds that will help us as we develop this out, but any experience with this at this point? Crickets. May it not be your experience. I can imagine that the kinds of things that we often use in those moments become then the surrogate for the person when you can't be with the body. So pictures, photo albums, video, whatever you might have, a chance to do at least some initial processing. It's also tied to a question about how then do you connect with community clergy or refer to community clergy, and what role can they play when there's such stringent limitations on visitation?
So I will say from our perspective, we have developed relationships with our community clergy, and we are in regular communication with them and really encouraging them to do some of the same things that we've been talking about today. I think Petra mentioned a few minutes ago, everyone has a phone in their room. So if they're not able to come and visit those members in person, to be contacting them in their rooms over the phone, and supporting the families in ways that that are appropriate as well, given our restrictions around social distancing.
Thank you. Anybody else want to add to that?
Ours is pretty similar, and just helping them figure out creative ways to connect with the patients and with the families.
The other interesting question is how to use some of these technologies, or what, now that visitors have been so limited, particularly with COVID-19 patients, how do you make connections from home or from outside of that space, not just between the chaplain in offering spiritual care, but helping facilitate the family and loved ones' interactions?
So this is Jennifer. I mentioned that a bit earlier, and one of the things that we're finding to be incredibly helpful is helping the patient FaceTime with their family, or contact their family by phone, whatever their normal. Most people FaceTime in some way, shape, or form, or use some similar kind of app. Whatever that is, that they can use their own device to be in conversation, is very helpful. I think most of our facilities do offer free Wi-Fi, and so how can we help them leverage that for connection, and continue to help them keep their community around them virtually, if not in person?
Yeah, and somebody raised a good point of, as the numbers increase, where family members will wait, that most ICU waiting rooms have limited capacity, and are the institutions thinking about triaging family members so that they have a place where they can be?
That's what our at Cincinnati Children's they're doing. And social work we are very lucky to have many social workers, and they are really helping us out with that. They're, they continue to have to change where the families can gather, but are being creative. And ours has a 2-person visitation list now. And so in special circumstances like end of life, how we can continue to maintain 2 persons, but potentially rotate those out. And it continues to change every day. Our guidelines change all the time of what we can do and what we can't do. And so our social workers have been really helpful with our families and with us as well, and helping us work through that.
That's great. Thank you. We are just about at the end of our time. I feel like we could continue this conversation through most of the night and try to figure things out together. Know that the lab will be working on developing some things, and I'll let Michael close us out in just a second, but just to say thank you to Petra and Deborah, to Daniel and Amy, to Kurt and Jennifer. Thank you for taking the time out to give some thought to this and to offer to our colleagues. Thank you for those of you who asked questions and made comments. We will try to gather all this stuff together, and I'll let Michael share the details of how that's going to happen.
All right, Trace, let me just turn on the webcam here so I'm not a disembodied voice. All right. Thank you all. Thank you all for being here today, and to all of our panelists. This is just so timely and helpful, and I really appreciate the great balance that you struck between kind of the theory underlying all of this, but just the practical elements of how do we do this right now, because these are not things that people need to know how to do a month from now or a year from now. It's like they're going to get off the webinar and go do it right now. So thank you very much. Everyone who is on this, we will send this out very, very soon. We have to do a little bit of minimal processing on it, and then we will upload it. It'll be on the Chaplaincy Innovation Lab website. Everybody who registered will get an email that has a link to that recording, and then we will also include all of the handouts that are listed in the controls over there. All of the materials that were mentioned here, the slideshow will be there, the sample scripts, all of that will be included in that message, so you'll have it handy for you. If you thought this was useful, please do pass it along, let everyone know that it's still available. It'll be on the website, indefinitely, so we want this to be a resource for everyone as long as possible. So thank you all for being here. I should ask the panelists, do you have anything else that you'd like to add before we close out? Well, we will be back together next Tuesday, March 24th at noon for another one of our town halls. We did one this past Tuesday. It's just an open space for chaplains to come and talk about what they're experiencing, what they need to exchange advice. We're going to have Donna Moat, who is a disaster chaplain and also the chaplain at Hartsfield-Jackson International Airport, which means that she has a lot more free time these days. Eric Skidmore and Peter Goditis, disaster chaplains as well. So some people that have some frontline experience in not necessarily medical crises, but certainly had to deal with moments of extreme need. So please do join us. The registration link is on our website, and we hope to see you next week. Thank you all for joining us. Have a great afternoon.